Good day, and thank you for joining. I am Sherilyn Francis, and on behalf of the Morehouse School of Medicine Prevention Research Center, we welcome you to part two of our mental and behavioral health matters webinar series. And now a few housekeeping measures. As participants, your microphones are muted, and we ask that you keep your microphones muted throughout the duration of the presentation. You can check your internet connectivity using the icon that is available via Zoom. Additionally, the Zoom does have a call-in number, so you can switch from voice over IP to the call-in number. We ask that you refer all presenter questions or panelist questions to the chat pod. There will be periodic stopping points for question and answer. Additionally, we ask that you submit all tech issues to the chat pod. Recognizing again, there will be time designated at the conclusion of the webinar for discussion, questions, and answers. Additionally, we will invite you to continue the dialogue within the PRC virtual learning community, and you will receive an email following this activity to invite you to that learning community. Additionally, you will receive a post-evaluation via email. And now, Dr. Akintobi.
Great, thank you so much, Sherilyn, and I want to thank all of you for taking the time out of your day to be with us to talk about this very important issue and our path forward. So I'm honored to serve as the director of the Prevention Research Center, and our mission is to advance scientific knowledge in the field of prevention in African American and other minority communities. And we say that because while African American and Black communities are disproportionately impacted by adverse health, sickness, and death when compared to other groups, we are very clear that not only are other communities of color important to us, but also the other ways that we define minority communities, whether they be by geography, living in rural or urban settings, whether they are otherwise abled, whether they are refugee or immigrant populations, and many, many others. We are clear that people have many layers of identity that require our attention. But whatever the case, we are clear that community leadership, community wisdom is at the center of the path from just looking at differences in health outcomes like health disparities to getting us to health equity, where everyone has what they need in the amount that they need it to live their best life possible. Next slide, please. So the work that we do, and that work involves you, it holds to the applied definition of community-based research and other approaches, because not everything we do is research, right? It must be dynamic. It must engage both community, research, policy, advocacy groups, all the types of people and organizations that move the needle towards not just talking about the problem, but also advancing solutions. It must be focused on prevention where we can, because we really want to roll back people's risk. These approaches must be tailored. There's not one size that fits all. And as I described earlier, our efforts must be ethnically or otherwise culturally focused. So today, we're going to be talking about issues related to mental and behavioral health. The issues for children, the issues for families cannot be the same. They must attend to all of the ways that we know and learn what works. And what you'll see featured today are some of our research experts, but more importantly, our community experts who will talk about really what is going on and how we can work together to make a difference. So I want to share a little information about each of them because we're going to be flowing through this. And more importantly, we want you to use the chat and other ways that Sherilyn guides us to make sure this can be as interactive as possible. So you're going to soon hear from one of our partners in good, Miss Cindy Simpson with Chris 180. She has over 35 years of experience working in Georgia's social welfare, youth and homeless populations, and mental health systems. And in her work with Chris 180, she has helped develop several new programs, including the Transitions Program at Summit Trail, and many, many others. So her work and that of Chris 180 is connected not just to mental and behavioral health, but all of the other ways we must be responsive. You also hear from Dr. Gigi Bastien, who is a assistant professor at Morehouse School of Medicine with a special emphasis on mental and behavioral health and all types of communities. And so she'll share some wisdom for us and some hopefully insights that really resonate for you, whether you lead in serving people or you yourself are looking for answers or ways that your voice can be heard. You'll also hear from Dr. Aletha Williams-Livingston, who will talk about FamStrong 21. And so for those of you who don't know what FamStrong is, you will learn here shortly. And then another partner in good, LaShawn Hoffman, who is the chair of our community-centered board, which has been expanded and modeled to many others that are really looking to ensure community voice, not just voice, but leadership in any initiative designed to advance the health of communities. So before I turn it over to him, I just want to frame this discussion and let you know that this is our Mental Health Matters 2.0, because last year this time, you might remember where you were May of 2020. You may have been on the front lines in service in different ways. You may have been able to quarantine, but we were just getting used to Zoom, and we were just beginning to wrap our mind around what we did not know was going to be over a year in the COVID space. And so we were clear before COVID through a community health needs and assets assessment that for the first time, mental and behavioral health emerged through our community partners and residents as something that was within the top 10 priorities that they were either wanting more information on or that they were seeing in their communities. So this was back in 2018. Then came COVID, and it made the issue and the relevance of the importance of mental and behavioral health all the more important, not So I encourage you to let your voice be heard during this time, and also to really be open to remembering that you have no health without mental and behavioral health. So think not just of only how you lead, but how you should mind your mental and behavioral health. So I'm going to turn it over now to LaShawn Hoffman, the chair of our Community Coalition Board.
Thank you. And I'd like to join you, Dr. Akintobi, in welcoming everyone to this webinar as we are going to dive deeper into this important discussion that affects us all. On behalf of the Community Coalition Board, I'd like to just simply say that we're excited that we're going to be having this discussion and that we have these partners that will share a bit more about how do we improve our mental and behavioral health. A little bit about the Prevention Research Center is that we've been engaged in research using community-based participatory research principles for over 20 years. Next slide. I've had the privilege of leading this board for over 10 years that are made up of community members, academic institutions and agencies. And this is a policymaking board that oversees and helps to identify health priorities and approve projects that come within the focus of the Prevention Research Center. Our goal is to also provide information on research information and to organizations and agencies to ensure that there are clear benefits to the community. And as trusted leaders, we want to make sure that the research that is being conducted benefits the residents in which we live, work, and play. Next slide.
So, Mr. Hoffman, those are the two slides that were specific to the CCB, but we do encourage you because obviously you are the lead of the CCB, so feel free to speak freely.
I think I'm ready to engage in this conversation.
Okay,
Yeah,
let's hop
let's
to
get
it.
going. Yeah.
Thank you. Well, Dr. Akintobi did a phenomenal job of introducing each of today's panelists. So again, we invite you to engage in this dynamic discussion where we are addressing our mental and behavioral health 2.0, recognizing the need and importance of focusing on child and family mental health in the era of COVID-19 and beyond. And now I will transition to Ms. Cindy Smith, Chief Operating Officer of CRIS 180. And I will stop sharing my screen now.
Okay, let me see if I can figure out how to share, but I'm pretty sure I can. Does that work?
No, we don't see it, but I can do it for you if you need me to jump in.
Now, you know, I should be able to do this. Okay, wait a minute.
And while Ms. Smith is preparing her presentation,
Does that work?
We are off, yes.
Okay,
Thank you.
great. Okay. See, sometimes I can get it eventually. Thank you for your help, though. And again, my name is Cindy Simpson. I'm the COO of CRIS 180. So just so people kind of get a handle, these are, I'm going to tell you a little bit about CRIS 180. And then I really want to go into what we're doing about behavioral health in communities. And behavioral health is one piece of it. It's kind of the centerpiece, but there's a lot of other pieces that go into it. So these are our core values: creativity, honor, respect, and integrity. And this is our mission. It's all about healing children, strengthening families, and building communities. And we're really looking at this as building safe and resilient communities. And so this is kind of giving you a picture about what we do. And as you can see, mental health counseling training, we do an enormous amount of training. And again, when we're looking at a community, where are the gaps other than behavioral health, which we know are gaps, but what are some other gaps? That's where safe housing, skill building, food delivery, care coordination, and how does that all fit together? And I think we have several programs that in the last 2 years we've put together that's working really well. This kind of tells you where we're at, where we're located, because one of the important points that fits in building a safe and resilient community is behavioral health, but it's also where do you deliver those behavioral health services? So as of today, we are in 62 schools, and we try to work with the schools that are in clusters. So elementary, middle, and high school, the cluster program. So every school of those 62 has a full-time behavioral health therapist in the school. And they also have a part-time, what we call a community behavior specialist. Also, all the schools receive, all the teachers receive trauma training and ongoing trauma training, which has definitely made a difference as well. So I just want to talk about 2020 because we all know 2020 was a different year. And so I just wanted to give you some data points to look at. So again, 62 schools, 6 different counseling centers that remained open through the COVID time. They're still open. We do intensive wrap services. That didn't stop during COVID either. And during the COVID period, really, it increased by 28%. But then as we looked at the communities, and I'll talk about zones. So when I talk about zones, we base this on the Atlanta Police Department of zones. So that's what that is. So when you look at zone 1 and zone 3 and zone 5 and zone 6, those are the 3 zones that have the lowest income in the metro Atlanta area, they also have very high crime rates. And behavioral health services have not been accessible. So in the past 2 years, really we can go back to 2017 when we opened the first At Promise Center. So on building a safe and resilient community, we talk about 2 At Promise Centers, the West Side Empowerment Center. We'll get into those more. Opening a helpline, making things easier for residents in those communities. Then a year and a half ago, we started a Cure Violence program, which has been extremely beneficial. We also do emergency assistance for mortgages, rent, and utilities, food delivery. I think the interesting thing about food delivery is that we actually do well checks when we do the food delivery, because that's an important thing to keep going. And we trained residents in each of those zones to help us with the food delivery, and we trained them how to do well checks, which is really basically just knocking on the door and checking in to make sure everything's okay. A perfect example to me with that is we delivered food to a mother and 2 children and her partner that was living there, and you could tell something was off. And so she basically whispered, "Call me after 5:30. We called her after 5:30 and it was a domestic violence case. And we got her out of the home and her children out of the home and safely housed within 2 hours. So that's part of that whole building a safe and resilient community. Trauma Response Network, we'll talk more about that, but it's really focused on the residents of communities. Same thing with Healing Circles. So just some data, it was interesting to look at 2020, and it was a difficult year for everybody. But when we look at, we continued to do training via webinars and Zoom. And we actually did trauma training for 1,395 teachers, which I thought was pretty impressive given the year that it was. Also did trauma training for the 2,311 case managers, therapists, and other providers that are either behavioral health providers or providing other social services. Behavior health, it's both insured, uninsured, and underinsured. We serve 7,015 individuals. Wraparound services, we worked with 1,492 families, which again, I was surprised at for 2020. And the total number that we served for 2020 was 16,841, which again was kind of surprising that was high, or as high as it was. So I wanted to tell you a little bit more about it. Yes, this is all about behavioral health, but again, there's other pieces that go into it. So all of our community locations, not our counseling centers, but like our At Promise centers and our Cure Violence, every one of those centers have a therapist, a full-time therapist, and a couple of them have 2 or 3. So that's important. Actually, they all have 2 or 3 now, because those facilities are in the zones that the residents live in, and it makes it accessible. And then community, all about being accessible, because a good example is until we open some of these community locations for behavioral health, people on the west side were having to ride the bus over an hour to get behavioral health services. So that was a problem. The other thing are our community programs. It's on-site therapy for residents and other participants. And whether you're insured, uninsured, or have private insurance, it doesn't make any difference. We don't say no. So you don't have to have insurance to receive behavioral health services. So At Promise is a unique design. just to give you a little heads up, it was actually designed because when a police picked up a teenager, 17 and under, they might take him to the police station and then they might sit there with him for 12 hours or 24 hours or longer. So, that was a waste of city money because they're paying time and a half. So we opened the At Promise Center as the initial thought was that it's really all about, helping the police, but also a lot of it was all centered around diversion. They don't have to go to court. There are ways that we can deal with it without doing that. So At Promise opened in 2017, the first one. The second one just opened in January of 2021. Focus is 12 to 24-year-olds. It also serves homeless youth and families. And it has a reentry program with the Department of Juvenile Justice. And then we did this other thing with APS schools, which never made sense to me when somebody's suspended from school, that they can't go to school. So then what are they doing if they're not in school? So we decided that the best thing to do in that zone, in zone 1, was let's do a suspension program, and the kids that are suspended would come to At Promise and still receive their academic credit. So that really helped. During COVID, we continued to have school for APS, and it was all done virtually, but it was done at the At Promise Center. So these are the pieces of the At Promise Centers. Again, they have 2 full-time therapists, and those therapists work in groups, as well as music therapy is a big part of the At Promise Center. Art therapy is, as well as individual and family therapy. When we first opened At Promise, I thought, if we get 100 kids to come and participate, I'd be happy. And actually, the first year in 2017, we actually had 341. It's grown now. So on zone 1, we actually have 821 participants at the At Promise program. So that's how people are referred, and this is what it's all about. I'm not going to read all this to you because to me, the important thing is that we looked at Promise, what's really working. Because again, we wanted to check out behavioral health. We wanted to see of those 821 kids and their families, what are they participating in? So it was interesting to see that the largest majority on their own, again, it's all about if we can engage you first and then look at what your behavioral health needs are, that more children will participate and more families will participate. And that's, you can tell from this graph, that's what happened. So it's all about engagement and then moving to behavioral health. So again, this is something that came up for Cure Violence. As some of you may have heard about Cure Violence, it's actually an international program or model. And so we raised a lot of private dollars in order to start a Cure Violence program. Right now, that's in zone 3, is the only zone in Atlanta that has it. We're hoping to increase that and do the same in other zones. But it was all private funding, and they have 2 full-time therapists. We're located on Lakewood Avenue there. So again, it's one of those pieces that we always, no matter what program we're doing or what center we're working with, we have behavioral health services there. Zone 3 was picked because it had the highest percentage of murders and shootings. And part of this model is looking at violence and gun violence as a disease. And that's kind of the mindset that you go with. Again, it's about engagement with these clients in order to then move to therapy. I think the biggest piece of cure violence is, you know, when we look at establishing who does what, it's all about how do you interrupt the transmission of violence? You know, how do you mitigate the risks? And you're working with the entire community to establish new norms. And so when we look at that whole building safe communities, you're looking at, we're in schools providing behavioral health. We have an At Promise Community Center. We have a Cure Violence program. So trying to go at this in many different directions, I think has really worked. The other thing that has been key is actually hiring residents of the community, just like hiring them to deliver food and do well checks, hiring them to be a full-time employee of Cure Violence. That's all done intentional. And that has really worked. I think one of the biggest pieces when you look at it, you've got 2 full-time therapists there, but the other thing we've added to that under Cure Violence is the Trauma Response Network. So we all know that when trauma happens in a neighborhood, in a community, you know, we know the police respond, but how do we train our community members to respond as well? So community members are helping each other once they can understand trauma. So right now in Zone 3, we have 28 trained Trauma Response Network residents. So when an event happens in Zone 3, the police call our Cure Violence team, and not only do 2 of our team members go, but 2 of our trained residents go to help as well. And this idea, we're actually taking this to high school students, because we all know kids listen to kids, you know. So we're actually going to train high school students in zones 1 and 3 to be Trauma Response Network trained as well. The other piece we've done in those zones is started healing circles. And really healing circles is really about a grief support group. And that is also facilitated by trained residents of the community along with our therapist. So I think those are some key elements that makes behavioral health accessible, and people begin to understand what behavioral health is all about. Okay, so that was Zone 3 and what's going on there. And I can tell you in all 3 of the zones, Zone 1, Zone 3, and we're in Zone 6, we're trying to get the same kind of programs going in each zone, but we work with the community for them to tell us what they want and what they need. So at the West Side Empowerment Center, and this really came out of, there's always a lot of different providers in the community. And sometimes providers step on each other's toes. So West Side Empowerment Center was all about how do we, originally was about how do we connect providers, how do providers work together? You know, Chris 180 is not a workforce development program, but there are workforce development programs that we partner with. So we're not, you know, a GD class. So we partner with those folks that do that. So at the West Side Empowerment Center, we have 5 community health workers. And so our community health workers and our 3 therapists work in tandem with each other. So they might be serving the same client. They might go to the client's home together, where our community health workers checking on their primary health, and then our therapist is providing therapy in the home or sitting outside in the in the yard having a conversation and doing therapy. The other thing the Westside Empowerment Center does is it offers these weekly support groups besides individual and family counseling. So I can tell you at the Westside Empowerment Center, we are now serving 237 individual clients. And it's just grown enormously, which again, we didn't know that how it would grow. And again, you don't have to have insurance to receive services. So the support groups came out from the residents telling us what they wanted, what they needed. So we have a parent support group weekly, we have an SA group weekly, and a domestic violence group weekly. Because as you know, during the pandemic, domestic violence has increased by 31%. We also have 2 care coordinators. Some people refer to them as case managers. There is somewhat of a different. The care coordinators are really connecting them, the residents or the clients, to other services that they need or that they want. The other thing we did was take a look at, and I hope I don't offend anybody here, but we took a look at how do our residents receive services that they want? So who do they call? Well, I could call this number, but they don't offer what I want. So then I have to call another number. Well, by that time, maybe I have to call a third number. Well, that doesn't work for people. So what we started last May is we started a helpline just for Zone 1, just on the west side. Within a month, Zone 3 will have a helpline as well. And it's really one number that you call, and then we can push the button. If you say, oh, I'm looking for a job, I can push the button and I can send you over to workforce development. So, or if you're looking for housing, I can connect you with Quest. If you're looking for behavioral health, then it's obviously you've already connected. If you're looking for a tutor, we can connect you right there. So you don't have to make more than one call. And that has worked extremely well. Again, we have trained residents from that zone that we've trained to run the helpline. And I think that's been a really important piece. I want to say one other thing that's not on here that is kind of a future thing, is we are in the midst of talking to the Atlanta Police Department, as well as legal aid, to actually do something different on domestic violence calls. What happens now on domestic violence calls is the police go to the scene, they get it safe, and the victims may or may not get services that they need, the individual and their children. It may be a week before they get services. So we need to change that. So under domestic violence, what's happening now is we're trying to change the future of that, where the police actually will call us and we will have what we call a mobile van. It'll have legal aid with it, as well as Chris 180 therapists and case managers. So the police will get the scene safe, and then we will work immediately in using the mobile van to have the victim and the children. We can do a behavioral health assessment right then. We can see what other needs they have, what do they want to do, and we can take care of it immediately instead of waiting a week. So it looks like that's probably going to get funded fairly soon. Okay, just looking at the future, because it's always kind of like, what's next, especially after, 2020, what is next, And there's a big question about telehealth. We do a lot of telehealth, but we also do a lot of face-to-face, because a lot of our clients do not want to do telehealth anymore. They're sick of it. So there's a big discussion about what's that going to look like once COVID is declared over, which I have no idea when that's going to be. But what's telehealth going to look like? So I think telehealth will still exist. I think we have to advocate on how, as behavioral health providers, how do we want it to exist? What do we want it to look like? The other thing in the state of Georgia, you know, many of you know, we did not expand Medicaid, which is a major problem in my book. So billable service like wraparound services. Why is that not a billable service in Atlanta or in Georgia? It is in other states, because there's enough data out there that says intensive wraparound services with a therapist and a care coordinator, that we keep children in their homes. It decreases the number of kids that go into foster care. It decreases the number of kids that go in and out of hospitals. The other thing that needs to change is community health workers. If you look at the numbers by data that have gone down using the emergency room as your primary health provider, that's gone down using community health workers. Behavior specialists. There's a lot of schools that really need a behavior specialist, and not that we're having a special behavior class, but that a behavior specialist can actually go in and into the school and help the teacher, really. Teachers, even though they've been trained, they continue to need coaching on how to deal with some difficult children. More accessibility. I think that's a major issue when you get to some of our zone areas and low income zones. And my big thing is, in order to get these things to change, or whatever else we as a group think needs to be changed, we need to advocate and work together to make those changes. And that's really the end. Again, everything that we've done, any program that we open, all is centered around, the centerpiece is behavioral health services. It's how you get there may be different in each location or in each program. So I appreciate your time. Thank you.
Thank you so much, Ms. Simpson. As we're transitioning to Dr. Bastian's presentation, we just have a few questions for you. And our first question is, for other organizations who may be considering starting some of the services that you have detailed for Chris 180, where do they begin? What is the first step?
Well, I'll tell you, I'll give you an example, because I got a call from Jacksonville, Florida, like 3 weeks ago. And so they called and we've set up a time to talk, or we did set up a time to talk. We had a long conversation, and then I'm happy to send people, you know, how we wrote everything up, how the program is designed. I'm happy to share that with anybody. Part of it is the funding. You know, it's going after funding, either federal grants or foundations, because of, again, our billable service problem.
Thank you so much. And another question, how do you determine whether or not the program that you've implemented is effective in the community of interest?
I think we do it several ways. So we do a lot of surveys. Again, I think hiring residents of that community is extremely important in order to do the surveys, but also it's the number of people and then the feedback from surveys. We also do monthly, in each of the centers, we do monthly community events. And, you know, like, I have to tell you, I didn't think this was going to work when we first did it, but we did like a haunted house. And I thought we'd have some kids show up. I mean, the entire community showed up. We had over 800 people. Once that happened, that connection happened, it was off and running. And so I think that's some of those things that you have to do.
Okay, wonderful. We have one more question from Terry Ross. And Terry, if you don't mind unmuting yourself so that you can ask your question.
Sure, sure. Yeah, I just wondering what Chris 180's involvement in the pre-arrest diversion program.
Yeah. So we are involved in the pre-arrest. We go at it from both ends. We also have a reentry program within the Fulton County Jail. But the pre-arrest program, it's part of the At Promise Centers for that age group of 12 to 24. And they refer them for therapy. They also refer them to the Cure Violence program. And so that's part of it. We're in the courts on a regular basis. So that's one of our care coordinators that's in the court with them. And that's make it easy referral. You can do it right there on the spot.
And thank you so much. So Cindy will be available in addition to all the other webinar panelists at the end of the webinar for more discussion, question, and answer. And now we will transition to Dr. Bastian's presentation.
Okay, thank you so much, Sherilyn. Thank you. First, I want to thank the Prevention Research Center for the invitation to touch a bit on this really important issue that I think COVID is helping to remind us as a society in terms of the priority of thinking holistically about the complete being, right? We know so much of what COVID has brought in the way of challenges has been under the umbrella of sort of traditional kind of medical systems and public health. But there also is this really critical aspect of what these kinds of events, what a virus of this nature can mean for mental health at the individual level, at the family level, and certainly at a broader societal level. And so that's the sort of the framing of a lot of my comments this afternoon will be some considerations in that vein. Next slide. So we know and have a growing body of science now establishing the fact that the pandemic has had significant effects on mental health for a number of swaths of our society and just about every sort of way that you can imagine. So we'll talk a bit on some that are relevant to our core population of focus here. Next slide. But before we do that, I think it's important to establish some shared language, right? So when we throw out the term mental health, that brings up a lot of different thoughts for folks in terms of what that means. And often when people think of mental health, their minds often go to sort of the most severe cases of mental illness, right? Of when there's a breakdown in terms of mental health functioning. But what we actually know is that mental health as a construct really is an umbrella term that captures an entire spectrum, right? That goes all the way from functioning well and evidence that, you know, exhibiting resilience and being at our best in terms of emotional functioning. It captures kind of the distress of just managing the day-to-day realities of being a human being and all the demands that come along with that, and stretches into where we have dysfunction or breakdown that can lead to a diagnosable disorder. And so I did want to share this being one of the definitions that I appreciate about mental health that gets at the idea that it has to do with how we're able to show up, right? How we're able to be our productive selves, how we're able to manage relationships, the capacity that we have to cope with the constant sort of curveballs of life. Are we able to manage those changes? It captures the fact that mental health has to do with our entire society from early childhood all the way, you know, cradle to grave sort of idea that it touches and affects every member of our collective society, and that it has everything to do with those abilities that distinguish us as a distinct member of the animal kingdom, right? The fact that we think, that we communicate, that we have a way of sort of learning and engaging that is really distinct. All of these things fall under this broader umbrella of mental health. Next slide. And so also important in that understanding is an important distinction, right? An important differentiation between distress or challenges that we might have in terms of our mental health functioning versus what we would categorize as a disorder, a diagnosable sort of a condition that folks might have, right? So when we're talking about distress, we're looking more at stressors that can come from a range of sources, right? Whether that's physical conditions that we have that create challenges for us. How do I manage my diabetes? How do I manage these different illnesses? financial stressors, right? And we'll talk a bit more about how COVID has challenged so many members of our communities on that front. Social challenges, right? When we're dealing with different social, cultural, political sort of challenges in society, that creates a burden for us to respond and to react, and affects our day-to-day in significant ways. Issues of inequities, injustices, those things also can create challenges that prevent us from feeling our very best, but that may not rise to the level of what we would require for a formal sort of diagnosis. And when we move into that other category of a diagnosable disorder, there are particular and very specific sort of features that we look for that from my sort of world as a psychologist are based on our diagnostic statistical manual, or DSM, that sets out specific signs and symptoms that we look for to indicate whether it's a formal major depression diagnosis, a formal post-traumatic stress disorder. And so that is important for us to consider, that even though we may not have something that rises to the level of requiring a diagnosis, we may still be dealing with something that requires some attention and some strategy to manage. Next slide. So putting this mental health issue in context as it relates to our current sort of COVID pandemic era. Next slide. There's some important considerations. And what we know is that for the past over a year now, we've been dealing with this monster of the coronavirus, but we haven't been facing that in any sort of a vacuum, right? This is a pandemic that landed in our labs in the context of a number of other sort of life and societal challenges. One of those being our current political climate, for example, which has also in some significant ways affected what COVID has been and what it continues to be and what that means for mental health functioning. We know that there have been significant sort of provocations of longstanding racial dynamics and tensions in this country over the past year as well, whether it's conjuring back to the marches around this time last year, what was happening with the George Floyd incident, and similar sort of events of community and law enforcement clashes. We know that outside of all those things, we have other challenges stemming from life conditions, social determinants, whether that's housing conditions, how folks are living, educational opportunities, financial realities that folks are dealing with. And so all of those things have sort of compounded to create a particularly significant burden as it relates to mental health for a number of members of our society. And it behooves us to consider that mental health picture in its entirety, and not just COVID in an isolated vacuum. Next slide. But in particular, as we think about COVID, we know that fear and anxiety are some of the more prominent and salient issues that have come up for us as a society. If you think back to this time last year when there was all the frenzy around toilet paper and making sure we had everything that we needed for quarantine, there was an air of sort of anxiety, panic, and fear prevalent in society. And we know that that has significant effects, not just for our mental functioning, but there's a physical manifestation of those kinds of emotions that challenge us as well. We know there have been significant disruptions to our routines, whether that's school for our children or work for our adult folks. And I should clarify that when I use the term children for the duration of this presentation, that captures both children and adolescents as well. There's been significant challenges in terms of employment, folks losing jobs, folks being laid off, folks having to take salary cuts. This means, constraints financially for a household, and that brings its own flavors of stress and distress. Feeling a sense of powerlessness, right? We know so much of what can cause us to feel unsettled as human beings has to do with feeling a sense of loss of control. We value pretty highly this issue of control as human beings. And so when we start to have that foundation of feeling that we can direct our activities challenged, it results in distress and in difficulties for many of us. And also, as the public health and medical community has been working to develop the strategies and the weapons to sort of respond to the challenge of COVID, we as a society have had to deal with how we respond and whether or not we're willing to receive those things, navigating issues of mistrust for the healthcare system and vaccine hesitancy as we move into these latter phases of our experience of this pandemic. So a range of challenges COVID has introduced to us as a collective society. Next slide. So what does this look like for our children, right? So capturing again that full spectrum from early sort of childhood all the way through to adolescents and young adults. Next slide. We know that if we consider sort of the distress piece that I described, that maybe is not quite diagnosable challenges, but things that are challenging nevertheless, we know that academic and social stressors have been a major issue for our young folks. If you can imagine, all that we associate with school, being able to be around our friends, being able to have an outlet for socially expressing ourselves, and having that in pretty short order being made, not accessible to our children, and having to now adapt to school being for some kids an isolated event with them and a screen at home, not having the regular day-to-day contact with their teachers, with their friends, and folks at school, has introduced some challenges and required some adjustments. We know that children sort of absorb and take in a lot of the stressors that are around them in their environment, right? And so as families have been around the table having discussions about financial stressors, having discussions about friends or loved ones who have gotten sick, who have passed, the grief issues that we're dealing with, our children are there in these spaces absorbing a lot of that energy and feeling a lot of the distress. So we know that certainly has been a factor in the era of COVID. And then also we've had noticeable upticks in diagnosable issues, particularly as it relates to anxiety, depression, and trauma-related issues, right? And some of that has come in the form of exacerbating or worsening some of the trends we were seeing even before COVID was on the scene. But also we've seen the emergence of new mental health challenges for children who had not previously had these diagnoses. And what's interesting with children is that we don't always see the manifestation of these challenges in the way that we might with our older populations, right? So often in children, issues like anxiety and a fear might manifest in what we describe as externalizing behaviors, for example, where there's more sort of acting out, more sort of aggression, more of a tendency to get into disputes with their siblings, with folks in the household. Whereas when it comes to issues such as depression, you might not necessarily, very few kids have the capacity to say to you, I feel depressed or down, but you may notice sort of what we describe as internalizing behavior patterns, where there's a sort of a withdrawal, where there's not as much interest in the things they used to be interested in. If they were really into a particular sort of TV show or cartoon, they don't seem as interested to do that. And they're not sort of their bubbly, cheerful selves as much as we might expect. These may be some of the ways that we start to see the signs and indications with this population that there might be an issue. And as my colleague, Ms. Cindy, alluded to in her presentation, we have absolutely seen an uptick in issues of abuse and neglect during this time, and really concerning if you consider that our kids have not been at school, where oftentimes that's where issues of neglect and abuse are being sort of detected by, whether it's by teachers or that they're physically reporting in for pediatrician visits, and having to deal with folks who are these mandated reporters who often will see signs of trouble and alert the proper agencies. Now with children being at home, there's not as much of that opportunity for these things to be caught. And so that is in itself a huge kind of challenge in this era. And then there are particular groups of children and adolescents that we know have significant challenges in this time, whether it's children with disabilities, children who had other sort of medical conditions, populations and communities with limited language proficiency. If you consider all the challenges with technology and all of that, to pivoting to this kind of virtual schooling reality, and having layered onto that you don't understand the language as a parent, and you're having to now help your child navigate all of that space. So significant challenges for a number of members of our society. Next slide. And a huge issue, certainly that requires more of our attention, I think, has to do with kind of the social interaction and loneliness piece that has really been challenged by COVID. We are by nature communal creatures, so that's sort of the kind of animal that we are. We need people and interactions, and a lot of that has been limited and constrained in the times of COVID. We were starting to already, as a public health community, think about loneliness and social isolation as a challenge, and COVID just really sort of magnified a lot of these issues. And folks have sort of used the terminology of the twist on quarantine to talk about what this has meant for our teens in particular, being isolated from their peers, having to navigate this particular time in their development when they're discovering who they are as social beings, and having all of that sort of suspended or stifled by this pandemic period. And so the challenge has been throughout this time, how do you balance that need, right? Knowing that we need to connect and engage, and really the one of the more severe punishments you can give to us as human beings is to isolate us. Knowing that, but also having to manage the safety considerations of an ongoing pandemic continues to be a challenge for us to strike that balance. And now as we move towards, starting to re-engage, starting to have our children back in school, starting to reemerge in the workforce, we're already starting to hear a lot about the social piece of that, right? And so some folks have literally talked about the idea of our social muscle sort of atrophying in this time. We haven't had to sort of practice engaging and having interpersonal engagement in the way that we typically might have during this past year. And so there is, particularly for our kids and our adolescents, some work around helping them to re-emerge and re-engage those spaces. Next slide. At the family level, I'll go through these quickly because some of these we touched on before, but certainly the domestic violence issues that have been alluded to before have been a critical issue. If we look beyond just the children in the home, but the parents and relational tension dynamics continue to be a significant challenge. Our parents are talking a lot now as we move into vaccination opportunities for adolescents and children about how they're navigating and making those decisions, right? How do you balance making sure that your child is safe, but fears that you may be, exposing them to potential side effects or potential adverse outcomes from, things that we're not as familiar with and that the science is still building around. And so these are very real challenges that we're hearing a lot about. And also, I think the pandemic has really brought to the fore in a way that makes it really difficult to ignore some of the pre-existing sort of disparities and challenges that COVID has exacerbated in a lot of ways. If we think about issues like pay inequality for women, that now it becomes even more of a prominent issue as women have been the caregivers who largely have had to make decisions around their careers that allow them to be at home to support the children and to make sure they're getting what they need to in the way of schooling. So now you have exacerbated gaps of career and professional opportunities. And so these are going to be important considerations for us moving forward. How do we attend to those members of our population that have had a disproportionate burden of those inequities in the period of COVID? Next slide. So with all those things into consideration, how do we begin to move towards solutions, right? And one of the models that many of us may remember from training and schooling as mental health professionals that is often helpful in the context of disasters and other humanitarian emergencies, whether that's what we're seeing now with COVID, whether it's what we saw with Katrina in 2005, whether it's what I've seen in other parts of the world around Ebola or earthquakes and hurricanes. We're often reminded that there are all these elements of needs that can sort of motivate and drive our behavior as human beings. But the critical pieces really start at the base, right? Really start with tending to the basics. And so what we know from the literature around addressing mental health in situations like this, like similar to COVID, in situations of crisis at the societal community level, is it becomes really important to address those basics, right? Making sure that folks are getting food, getting sleep, adequate sleep, those kinds of things, before we can then proceed to issues of security and safety, before we can then think about reestablishing those communal connections that really help us to be our best, after which we can move into those green and blue sort of elements of who we are. But this gets at the idea that we're complex beings and that our needs are driven by all of these variables, but starting with the basics was something a lot of us were reminded of in a really striking way in the time of COVID. Next slide. And so if we think about how we respond in sort of tiers, and I think of it as the first line of sort of response or defense starts with those things, those responses, those strategies that we can manage on our own, right? And so some of that, as I just referenced, starts with the basics, right? So during this past year, I myself have had to implement, an afternoon sort of walk for 15 or 20 minutes to get some sunlight, to get some exposure to green spaces, to get some fresh air, ensuring that I'm getting adequate sleep, right? Those are things that we can manage as preventative measures to help shore up our mental health functioning. Really paying attention to ourselves. We know ourselves best when it doesn't feel like we're quite ourselves, like something is off in the way we're communicating, or it's taken less for us to sort of lose our patience. Those are indicators that we might need to pause and tend to ourselves and activate our coping strategies. Turning to spirituality, prayer, meditation, these practices that can help to level us out when we're being challenged. Creating space when it comes to our children, creating space for the conversation, right? So asking, how are you feeling? What are you worried about? What are you concerned about? Creating that culture of open communication and dialogue becomes really critical. Putting things in perspective, right? There's no doubt COVID has been a monster for us to deal with. And we could probably also point to ways that things could be worse right now, right? If anyone's turned on CNN recently and seeing what's happening in other parts of the world where literally war is imminent, there certainly are ways that we could be more challenged. And so still finding, even in the midst of these challenging times, reasons for gratitude helps immensely. Visualization, thinking about better times and using the power of our imagination can be a really powerful way to lift our mood. Turning to community, right? We've talked about the power of connection, but being selective in that, right? So, because not all community is uplifting, and not all connections and interactions are ones that support us, right? Not getting pulled into that vortex of venting and stewing in negativity, but finding those spaces where we can be uplifted. Looking to things like writing, journaling, engaging in pleasurable activities. These are all ways that we can activate our own sort of first line response to mental health challenges. Next slide. But then as we move from those, trying those strategies, if we notice that we're still having some difficulty, still seeing those slides, there are a number of indicators that it may be time to call in the reinforcements, to look in for additional professional supports, right? So when we start to see an impact in the work that we're able to do at home, and when we start to see decline in the academic functioning of our children, they're not able to engage in the community or within their church groups in the same way that they were before. These may be indicators that we're moving from that distress space into more serious challenges that may warrant sort of a diagnostic sort of conversation. When we start to see negative coping, right? Drinking, drug use, which have really ticked up in the time of COVID, other risky behaviors, those are also indicators that folks are not finding ways to deal with the stress and are then turning to adverse behaviors. When we start to see the anxiety, the depression, whatever those challenges may be, creating interpersonal tension in the home, in our families, those also in the form of frequent arguments, those kinds of things may also be indicators we're getting into more serious territory. Next slide. And so if and when we start to identify those indicators of more serious challenges or distress, it becomes really important to look to those resources for professional support. And you can just click the arrow through. And sometimes that requires intervention at the level of a psychiatrist to consider medication, but oftentimes these challenges can be managed through behavioral strategies that don't quite require medication, whether that's with a psychologist, with social workers, clinical social workers, mental health counselors, marriage and family therapists to manage some of the relational issues we know have come to a head between couples in the times of COVID, and also thinking about pastoral counselors, right? So our faith leaders are an important resource in our community that often we don't think about enough in the context of mental health functioning. I know in my community, I'm originally from Haiti and pretty integrated into the local Haitian American community, and folks are much more likely to pick up a phone and call the pastor or the priest than they are to call Dr. Bastian about a mental health challenge. And so it becomes really important for us to think about those community leaders as a part of that broader network of support for our communities when it comes to mental health functioning. Next slide. Also wanted to share some emergency resource information. Right, so if you think about this tiered approach, we talked about the things that you can manage on your own. We talked about when we start to see challenges, who are the folks that we can turn to for additional supports. But when we're dealing with a legitimate sort of mental health crisis, it's also important to have some of these resources in your toolkit, whether that's being able to call the disaster distress hotline, the crisis text line I like to share with folks, particularly as it relates to our teens and adolescents, because many of them are constantly on the phones. And literally, this is a resource that's manned 24/7 by licensed and trained clinical professionals, mental health professionals who can, if they're up at 2, 3 o'clock in the morning, anxious thoughts and worries are stewing, they can find someone on the other side of that text to help them think through a strategy for finding solutions. And always 911 is a resource. But also wanted to share the suicide hotline resource, because we have also seen a really disturbing uptick in suicidal ideation within among our teens and our young folks over the past year. So encourage folks to share these resources and these numbers with folks in your network. Next slide. A couple of other things at a number of tiers, right? So we've talked about some of the strategies folks can activate at the normal level, but really the critical piece starts with normalizing the things that we've been talking about, right? Helping folks to realize we have been through and are still navigating a really difficult challenge with COVID, and that comes with mental health repercussions, right? So we're not sort of on an island when we're bothered by these things, but these are expected responses to an abnormal challenge. At the family level, I think creating that culture of open dialogue, as I talked about, so having a shared understanding about the importance of these issues and talking about the opportunities to support one another becomes really important, and appreciating that these conversations look different and are in many ways affected by culture and our cultural values and how we tackle those, and whether we bring in additional folks such as religious and faith leaders to help us in navigating those discussions. There's also a role for community, right? And part of that role is exactly what we're a part of right now. For example, creating spaces for community level discussions about these things, finding opportunities for education, awareness campaigns, seeing where there's an opportunity to advocate for different, if we work in a health context and we notice that there's some things about the ways that we're doing testing or vaccination that are not adequately considering trauma history, for example. Maybe we advocate for trauma-informed ways to do vaccinations and provide testing for our communities, right? So what are those opportunities for us to be a voice for folks? And then broadly, I think, and this is one of the things that I really appreciate about the work of the Prevention and Research Center, is always having an eye to thinking about the policy solutions and thinking about how we get to these root causes of the inequities that COVID is really bringing to the fore in a really prominent way for us at this point. Next slide. And yeah, that brings me to the end of my comments. So I'm not sure how we're doing on time with questions, but happy to address any that we have time to take.
Dr. Gigi, you did a great time with time. So we do have a few questions for you. And again, as a reminder, feel free to submit your questions in the chat box. First question is actually a two-part question. And that question is centered around communication. So how do we, as more senior members of our family, communicate with more junior members of our family to find out if they are really okay? And the second part of the question is, how do we, as junior members of our family, communicate with the elders within our family to find out if they are really okay?
Such a great question. And I think it points to so much of, what the generational differences that we can see in even the willingness to have the conversation, but also having the language of knowing how to tackle. And I think it starts with cultivating a culture within our families where these conversations can happen in the first place, right? And so that's not a thing that we do in one conversation or as a one-shot deal, but finding ways. If in my family, for example, there's a practice of nightly sort of dinners, is there a way to incorporate in that conversation? How's everybody feeling today? What was your rose and your thorn for the day? We used to do the rose and the thorn report. What was the high point and what was challenging about the day? But in the context of our conversations about children and adolescents, I think often we forget just how much children are attending to and paying attention to how parents are dealing with and navigating these things. And so what we do and how we respond becomes so much more important than what it is that we're saying. And so I think the opportunity to model in this time as parents for our children and the young folks in our lives what it looks like to talk openly about the fact that I am scared about, this time that we're in, about the vaccines, about what will happen in the long run. Here are the things I'm worried about. And from that space, moving a conversation forward. So I think often the way to open that door is to start with disclosure of our own experience in the places where we've had our own challenges, and that can often create the safety that gives someone else permission to step up and share the things that they want to describe. But to me, that's the biggest thing, the finding the specific sort of resources and where to point folks thing. More often than not, a quick Google search will get you that, but it's what's the culture that we've created as a family around talking about difficult things. And that's something that we can start to shift over time by looking at these small ways to give permission to one another to have difficult conversations. So that would be my recommendation on that piece.
Thank you so much, Dr. Bastiano. We have one more question as we're transitioning to Dr. Livingston. And the question is, how do we go about healing from the PTSD related to COVID-19 here in the US and globally?
Yeah, such a critical sort of issue. There's certainly a fair amount of trauma around what this has brought up for us as a collective, and all that has been happening around and alongside COVID. So part of that process of healing, I think, really importantly starts with recognizing where we are, right? So that's the initial sort of step, right? Is awareness within ourselves that I've been affected significantly and adversely by this period that we're in. And from there, looking to see how we start to make sense of that through those first tier sort of recommendations that I made. So that initial work might look like journaling to sort of collect your own reflections around what has changed for me. How has my view of myself shifted from before this period that we're in to now, right? The who I was, Gigi, who I was in February of 2020, I don't think is the same woman who's speaking to you today, right? And so reflecting for ourselves on what has changed about me, what has changed about the way that I know and understand the world, and then identifying what do I need to sort of make sense of all of that? And for some of us, we'll turn to our faith traditions to start that next phase of making sense of what's the meaning that I draw from all of this. What does it mean that this thing landed in our lap? What are the lessons that I want to extract from this? But if we're noticing some of the things that we talked about, right? If we're noticing that the ways I've been affected by this period has meant that I'm now not able to engage people and not to connect in the way that I might, has meant that now I'm not able to function at work in the way that I typically might, has meant that I'm not able to be as productive, that I'm not able to show up in my community, in my church in the ways that I would want. That may warrant then turning to someone for support, right? Looking for someone to sit with, a therapist, a trusted individual to move that work to the next level. And so I know I've shared some emergency crisis resources. There's some additional resources that have been brought together in this time also that can be helpful for folks. Therapy for Black Girls, for example, has a directory that they have pulled together that allows folks to find therapists of color, Black therapists across the country, which can be harder to find at times. The APA, the American Psychological Association, has an online resource through Psychology Today that will allow you to do a broader sort of directory search for a therapist by zip code. It will tell you who are the folks within a 20, 30-mile radius who can provide therapeutic sort of supports and resources. So these can also be a resource in starting to do this healing. But one of the things I'd love to see more of is how we tackle this as a community, right? So because recognizing COVID has challenged us as a collective, and my sense is that we are just at the tip of the iceberg, scratching the surface in terms of the consequences of COVID for our mental health functioning. And we don't have enough specialists, is the honest truth, to tackle that level of societal level kind of need. And so a lot of this work is going to need to move through our communities. And so I know at Morehouse School of Medicine, we welcome the opportunities to partner with community, with our faith community, with other organizations who have the connection and the credibility with community we may have the right message in terms of what things folks need to do, but Dr. Bastian doesn't always have to be the messenger, right? So I think looking for those opportunities as community members to partner with professionals, to be a spokesperson, to be an advocate, to be a champion for mental health, to share your own sort of story and create space that can oftentimes touch a lot more folks than I can in one-on-one therapy. And so that would be my encouragement also, is to reach out to folks like me for opportunities to think about broader impact within our communities.
And thank you so much, Dr. Bastian. And we will now transition to Dr. Livingston. And I would like to draw everyone's attention to the chat box. There is a form that you can download, which Dr. Livingston will discuss during her presentation.
Hello, everyone. So we wanted to make the learnings from our talk today tangible for our children, families, and communities, and really help all of us help our families to foster better mental and behavioral health. So we are excited to announce our annual family engagement program, FamStrong. This is FamStrong 21. So the Prevention Research Center's FamStrong project is an annual family and community strengthening designed to offer small bites of information in a casual atmosphere. So many of you joined us for FamStrong 20 last summer and fall. We enjoyed 13 family-focused health webinars with topics including the history of health disparities, mental health, and COVID-19. And we are going to continue the fun this summer. So FamStrong 21 will look a little bit different, but still be exciting and engaging for families. So how we'll work this summer is, starting in June, families who register will receive a FamStrong 21 box in the mail. It'll have all the items that you'll need for participation in the fun activities. The box will contain some comic books. Yes, comic books are very effective. So comic books, some activity cards, and other fun items and surprises. So the fun starts July 2nd and ends April 6th. Each week, families will receive a one-page email newsletter, so with a reminder to participate in the fun mental health focused family activities found in the box. They can do this in the comfort of their own homes. So week 1 will be a welcome to FamStrong 21, an overview of mental health and how the pandemic has affected us. Week 2 will look at our emotions, stress, anxiety, depression, life challenges, and other stressors. Week 3 will focus on our body. So the physical manifestations of some of these stressors, the brain, and also like how what we eat affects our mental health. Week 4 will focus on self-care. Like, what does that really mean? So we hear that term a lot, but what does that mean for us individually as well as our families? And week 5, developing your family's mental health care plan and also support resources. So the cool thing is that families can win points to enter in our grand prize drawing. So families win points by completing weekly activities and posting on social media. The grand prize is up to 5 family Fitbits and MSM swag bags with a whole bunch of good, fun and cool stuff in them. And 2 runner-up families will receive 5 family swag bags each. So this is a fun way for families to learn about mental health and have fun while doing it. So please circulate the flyer to your networks and click the sign me up button on the flyer to register and receive your box. So this is a no cost activity to the families. It is geared toward anyone. So it's gonna be really fun. So anyone in the family can participate. And I think we're gonna have a great time this summer. So please let me know if you have any questions. You will also get the flyer with the recording for today and the evaluation. So thank you so much.
Thank you. And once again, we have placed the PDF of the flyer in addition to a link for anyone who is having trouble downloading the PDF. Those can be found in the chat box. Additionally, we will ask that if you have any questions for the presenters to please place those in the chat box as we are transitioning towards the close of our webinar. We have a little bit of time for discussion, question, and answer. And there have been a few burning questions that I want to make sure that we have an opportunity to get to. For all panelists, please feel free to answer. We may be able to only get to one question. I apologize. Are any of you aware of any activities or interventions which are taking place to increase the number of people of color in the space of providing mental health services? Specifically, African Americans, Black persons, and Latinos in the space of increasing mental health professional representation of people of color. And I think Cindy discussed some of the work being done at Chris 180. So I see you just unmuted yourself, so you may be able to begin the answer to this.
Yeah, we have, I mean, that is a major focus in the zones and areas and the counseling center there is. In fact, because we're doing some immigration work with the immigrant children, you know, we've also made it a point to hire, and we give incentives or bonuses on hiring bilingual staff, African Americans. We have several Asian staff members that are therapists as well. So we've made that a point, looking at where the location of the facility is and what the needs are. And I think the incentives and kind of coming on staff has really helped. We pay for all their CEUs, and they every therapist in Chris 180 can identify what certification they want as far as certified in evidence-based practice. And Chris 180 pays for that as well.
Yeah, what I would add to that is I think much of the mission that drives the work of Morehouse School of Medicine as an institution is around that very sort of issue. So I appreciate the question. So certainly the work that we do to increase the number of folks who are matriculating through as medical students, many of whom We've seen an increased sort of interest in psychiatry as a specialist. That's part of the way that we're trying to address the shortage of folks in these areas who know enough about the issues affecting our communities and who care enough about them, as one of my mentors, Dr. Satcher, speaks of often, identifying these folks who have a connection with the communities that are most adversely affected by mental health challenges, and have a cultural understanding to be equipped to assist those communities. So some of that is through the work that we do to educate and train the next generation of health professionals, which include mental health professionals, but also we have a couple of lines of work under that workforce development kind of initiative that looks to our community, right? Dr. Livingston could talk a fair amount about the work that she does with community health workers, and we've been looking for funding, which we've discussed, that drives a lot of what we're able to do in this space to train community health workers that have an emphasis around mental health in particular. And that's work that we've also tackled in the context of other disasters and emergencies, right? So when, for example, my team and I worked in West Africa after Ebola, we looked to see how do we engage our faith leaders in training? How do we leverage Ebola survivors who themselves can go out and provide some emotional support and be able to disseminate resources within that community of survivors as it relates to mental health. And so from that same premise that I talked about, that the challenges of mental health that we're seeing, not just in the US, but all around the world, even before COVID was in our lab, suggests to me we cannot specialty train our way out of this problem. Like, we're going to need more hands than we have specialty trained, PhD level, MD level, master's level, et cetera. There really is work that has to be done to elevate the public consciousness, the public sort of understanding of what mental health is, what mental illness is. How do we incorporate some baseline strategies before we can then identify the more severe cases, where then I think that would be the appropriate place to sort of activate the specialty trained folks. And so much of my work around disasters and other humanitarian emergencies has been to look at what are the community resources, who are the folks in communities that we can help to train and collaborate and work with to begin to do at least the first tier of that work around addressing mental health needs. So those are the kinds of efforts I hope to see more of training community mental health professionals who can help to tackle that work. Dr. Livingston, I don't know if you want to share more about how you've championed and led a lot of that kind of work.
You're still on mute. So while Dr. Livingston, and I hope we have time for another question, but I think a part of the pause in the response was that there is a lot of work to do, and there are not enough people who look like those that are suffering most in service and trained to be responsive. And that, again, does not just mean those with a clinical or research degree. It requires all of us and takes all of us. So really, elevating the visibility of community residents, community health workers, to really have those conversations. In many cases, they're more trusted than those of us with a degree are. So it's an all of us thing, and it requires an all of us solution.
Thanks, Dr. Akintobi. I think that worked. My computer was like, I'm done with this Zoom call. So it kind of got frozen. But yes, I echo what you just said and what Dr. Bastian said. So many of you know I have a high school and young adult community health worker training program. And the purpose of that program is really to help young people, really be able to help themselves, their communities, and their families, with health challenges, including mental health challenges, and also to get them interested in some of these careers. So, as Dr. Bastian spoke about, we have a shortage of health professionals. And if we can talk to, young people, we can get them interested and help them follow their interest and, really kind of follow that career line. And so community health workers, of course, are very valuable. Everyone on the call has talked about community health workers, and they are just vital, you know. So we work with community health workers in many of most of our community facing projects. And, you know, I think that it is really something that, you know, the advocacy piece is something that we really have to work on to make sure community health workers are paid appropriately, and to make sure that we can bill for the engagement of community health workers. So, you know, the struggle continues with.
Thank you so much. And if you, as the audience, will indulge us for one more question, and this question again is open to all panelists. And the question is, how do we as community members initiate the work of acquiring mental health services within our communities? Again, community initiated work to engage professionals, researchers, or service lines. I'm sorry, was I muted?
No, I
I
heard the
think that
question.
we can,
I didn't quite understand it, so.
Okay.
Yes, thank you, Cindy. Just one more time, real quick.
Okay, so I'm going to seek to interpret. How does community initiate the work of ensuring that community is receiving mental health services, as opposed to an organization or a research entity indicating that the community may need resources? So I'm a community member. I realize that there are mental health issues or challenges, or even environmental or societal challenges, which are impacting the mental health of persons within my community. How do I initiate and build support within my space?
Okay, I can tell you a little bit about doing it within the zones, because every zone has an NPU, and a lot of things and that's really run by the residents of that community. And a lot of questions are brought up during that time at NPU meetings. Also, and residents actually, you know, they run for office, so to speak. So whoever the chair is a resident. And that's where I would tell people to start. Here's the needs of our community. Now, how do we all work together to get there? So behavioral health is one. Other things in their community, what's the other thing? So that's where I would start if I were a resident in that community.
I think one of the other opportunities is to really tap into your local health department. What we've discovered is that the local health department has a lot of resources that are untapped by community residents. I think people have certain perceptions of what happens at local health departments, and behavioral and mental services is not one of them. And so there are a lot of health departments across the country that at least offer or can connect you to additional resources. So you can start there. And with a quick needs assessment, or I should say an asset assessment of what's available first, right, in your neighborhoods, and then how do you then get connected to those resources?
I would echo much of what has been shared. I mean, I think the critical start is to facilitate community speaking to what community needs best. So whether that's through needs and assets kind of mapping initial work, or convening sort of listening sessions to hear from folks about priorities. We've been for about the past year and a half engaged in that kind of work with some of our local immigrant and refugee communities to help give voice to what are the priorities that you're seeing in terms of mental health, what are the needs, and then allowing that to drive what we pull together in terms of programs and interventions. But so often we jump into what we think, like my sort of specialty is trauma. I might think I need to go out there and start doing trauma interventions when folks may be more interested in what's happening with addiction and drugs right now. So I think starting from that humble and listeners kind of mode and stance really allows us to hear the heart of the needs from community and moving only from that base. So absolutely echo what my colleagues have shared.
Thank you so much. And we have reached the conclusion of our webinar. So I will ask each of our panelists, as we do at the conclusion of every webinar, can you please provide us with your charge forward for us as professionals and as community members? And we can just go in the order as you appear on the screen. So your charge forward for us as we are moving forward in the area of COVID-19 and beyond. And Cindy, if you wouldn't mind kicking us off.
I will kick you. I was just going to do that. You know, when you get older, you just speak up. That's how it is. So, so as I said at the end of my slides, and all of the colleagues here have said it as well, we have got to get together to advocate for some change. And, you know, when we talk about community health workers, and it's not a billable service. So we need to work together and advocate for these changes that have to happen. And behavioral health needs to be accessible in all communities. I don't want to go outside of zone 6 or wherever to go somewhere for behavioral health services because they don't exist in my zone. So, but we can advocate for those things to change by going to the State Department, writing legislation, going to our DBHDD board, as well as the Department of Community Health. We can go right to Director Berry or Commissioner Berry for that. So I'm gonna put my email address in the chat. And if you're interested in meeting with Commissioner Berry first, let me know, because I am in the midst of setting up a meeting to force the issue of some more changes that need to happen.
Excellent. I would offer two charges or two things. One is to be a part of facilitating discussions around these issues, right? A part of creating that culture of permission to discuss these things, whether that's in your friend group or in your family, finding a way to strike up a conversation that challenges folks to talk about how they're really doing. If there's that kind of a history of trust there enough that folks will do it. So being the force that opens up that space in your circles of influence. And then the other would be to share some of the resources you learned about today and not keeping these things to yourselves, right? So whether it's the emergency resources, crisis lines that we referenced, sending a blast through social media or sharing within a text group, because we never really know who might be in need of some of those supports. So those would be my charges: to one, strike up the conversation within your circle of influence, and two, facilitate sharing emergency resources within your network.
So let's see if this is going to work. Okay, it's working. Okay, yay. So my charge is very simple. Please sign up for Fam Strong 21. Share it in your networks. Encourage others to sign up and join us in July. We're going to have a lot of fun.
My charge would be, just as Dr. Bastian and others have said, is to continue to have these conversations, to normalize the conversation regarding mental and behavioral health, and that you can start that within your own families at the dinner table. I love that whole notion about the rose and the thorn. I think that's pretty awesome, and it's a great way to get people to start to share a bit more and to understand that that the more that we have these conversations, the better we are going to be, and that's the collective we. And so I want to thank you guys for attending today's discussion, and can't wait to continue this conversation.
So I agree with all that has been said, and would only add that our ability to be effective in having the conversations, in pointing people that we care about to services, it starts with us also focusing on our own self-reflection. You can only support if you are strong and have attended to yourself. So frequently, health from the neck up is the last that we focus on. But just remember, there is no health without mental and behavioral health, and it starts with you. We are in unusual times, so it's okay to not always feel okay. And so start with yourself. You can only help, serve, and facilitate support when you are well. So mind your health, mind your mental and behavioral health.
Thank you to all of today's panelists for a highly engaging and informative presentation and discussion and question segment. Additionally, thank you participants for spending your afternoon and early evening with us today. Again, you will receive an email that contains the post-evaluation. The recording for today's presentation can be found on the PRC website, and that will be emailed as well, in addition to Dr. Livingston's FAM Strong Flyer, for which you can register for those events. And on behalf of the Morehouse School of Medicine Prevention Research Center, we thank you for attending today's Our Mental and Behavioral Health Matters 2.0 webinar series. Thank you and have a wonderful afternoon.
Thank you.
Thanks, everybody.